Hello students, myself Dr. Jayabalan, Assistant Professor from the Department of Oral Pathology and Oral Microbiology from Vinayaga Mission Sankaracharya Dental College. Today the class topic is on periodontal disease. So periodontium comprises of gingiva, periodontal ligament, root cementum and alveolar bone. So these are the components of the periodontium. The main function of the periodontium is to attach the tooth to the bone tissues of the jaws and to maintain the integrity of the surface of the mastication mucosa of the oral cavity. So this is an image where you can see the attachment gingiva, cemento-enamel junction, marginal gingiva and free gingiva. So coming to the topic, the pellicle. Thin deposit formed shortly after eruption on the exposed surface of the tooth. As soon as the tooth erupts, there is a thin deposit formed shortly after eruption on the exposed surface of the tooth. Usually invisible, and it is probably of no pathological significances, reformed with minutes of polishing and fully formed in 30 minutes. Reaches its maturing thickness of 0.1 to 0.8 microns within 24 hours. So it is a brown pigment, presence of tannins. Pellicle frequently penetrates the enamel, especially on the proximal surface of the tooth. Histochemistry and the electron histochemistry indicates that pellicles are of salivary origin. It is a mucoproteins or glycoproteins. Primarily amino acid grows and it is 1:2 glycol groups. Coming to the stains, dental stains are we frequently inquire in the clinical cases. Dental stains or pigments deposits on the tooth surface. It may be either extrinsic or intrinsic. Oral flora in many cases contains chromogenic microorganism. Intrinsic stains incorporated into tooth structure. Example: porphyria, erythroblastins, fetalis and tetracycline therapy. Stains from smoking. Collections of tobaccos and resins. It is usually yellowish brown to black deposits, light brown, powdery deposit, occasionally cigarette. Dense black tarric deposits, heavy smokers. If the dentin is exposed as an older patient by attritions, the staining may be severe. Coming to the brown stain, it is a thin brown delicated pellicle like structures that occurs on the teeth. Composed of saliva mucin, closely adjacent to the orifices of the salivary gland ducts, tends to conform its relation to saliva. As you can see the mesenteric lines, so these are the lines. It is a delicated pigmented dental plaques, brown or black dots that coalesces to form a thin dark line on the enamel at the cervical margins of the tooth. Its presence is often associated with relative freedom from dental caries. So usually there will be an absence of dental caries when there is these lines are formed. These lines are called mesenteric lines. Coming to the black stains, it is a thin black deposits seen in children and adults, narrow line or band just above the free gingiva, not associated with smoking. So this black stain is not associated with smoking. Chromogenic microorganisms, although none have been identified or cultured from adult stains. Black stain on primary teeth is associated with low incidence of dental caries. Usually actinomyces species is involved. Coming to the green stains, mostly children, usually a heavy grey green stains will be seen, especially prominent on the gingival third of the maxillary anterior teeth, which is soft or furry and it is difficult to remove, associated with the enamel cuticle. No chromogenic microorganisms, remnants of Nasman's membrane, possibly by blood pigments. Usually the Nasman's membrane will be present during the birth. So if there is a remnants of this Nasman's membrane and there is a possibility of blood pigments, and then the green stains can occur. Coming to the orange stain, light, which is light thin deposits of a materials of brick red or orange color. Cause of this stain is usually not known, but it is also believed to be due to pigmented producing microorganisms. It is easily removed, no apparent significance and may or may not recur. Coming to the halitosis, the next part of the periodontal disease. Usually it is an unpleasant or foul odor exhaled while breathing or talking. It may be transient or persistent. Transient, present in all for some times, usually fasting, eating certain foods such as garlic, onions, fish, sometimes obesity, smoking, alcohol consumptions. So when it is persistent, it becomes the mouth in dry and in inactive during the night. Usually it worsens upon awakening or morning breath. So there are two etiological causes. They are local causes and extraoral causes. The local causes is tongue and gingiva sulcus, retention of food debris on and between the teeth, unclean processes. If patient is wearing in processes for so long time and it is not cleaned, it has to be cleaned, or else it is one of the factor for halitosis. Diseased state like chronic periodontitis, dental caries, abscess and dry socket. Extraoral causes: respiratory tract infections, hepatic disorders, excretion to breath of metabolites, alcoholic breath and uremic breath of kidney disease. These are the extraoral causes. So coming to the pathogenesis, the retention of protein in the oral cavity, mainly food debris, desquamated cells, saliva or plaque, which leads to action of anaerobic bacteria, especially on the tongue, dorsum surface of the tongue and periodontal pocket. This action of anaerobic bacteria leads to the breakdown of the protein. This breakdown of protein leads to amino acids. Amino acids, further degradations of amino acids causes productions of volatile sulfur components such as hydrogen sulfide, methyl mercaptan, which leads to release of foul odor. So retention of protein or retention of food debris in the oral cavity is one of the main factor for halitosis. This leads to actions of anaerobic bacteria which breaks the protein. The protein releases the amino acids. The amino acids further produces the sulfur compounds and that leads to foul odor. So coming to the classification of periodontal disease, coming to the gingival disease, it is a plaque induced gingival disease or non-plaque induced gingival lesion. Chronic periodontitis, localized generalized, it is again divided. And aggressive periodontitis, it is divided into localized generalized. Periodontitis as a manifestations of systemic diseases, necrotizing periodontal diseases, that is necrotizing ulcerative gingivitis, necrotizing ulcerative periodontitis. Abscess of periodontium, which includes gingival abscess, periodontal abscess, pericoronal abscess. Periodontitis associated with endodontic lesions, endodontic periodontial lesion, periodontial endodontic lesion and combined lesion. Developmental or acquired deformities and conditions, that is localized tooth related factors that predisposes to plaque induced gingival diseases or periodontitis. Mucogingival deformities and conditions around teeth, mucogingival deformities and conditions on edentulous ridges and occlusal trauma. Coming to the gingival disease, it is broadly classified into dental plaque induced and non-induced. Coming to the plaque induced, it is a local factors, systemic factors. Systemic factors affected by local factors modified by the specific systemic factors of the host. Plaque induced of local factors is microorganism, calculus, food impaction, fault or irritation restorations or appliances, mouth breathing and tooth malposition. Coming to the systemic factors, nutritional deficiencies, drug action, endocrine changes associated with puberty, pregnancy, menstrual cycles and diabetes mellitus. And another factors are allergic, hereditary, psychic phenomena, specific granulomatous infection, neutrophil dysfunction and immunopathies. Microorganisms, biofilm or plaque, many varieties of oral microorganisms are involved here, most commonly on the non-self cleaning areas of the teeth, particularly below the cervical convexities of the crown and in the cervical areas. Early diseases which includes cocci, various type of bacilli, fusiform organisms, spirochetes. Complex and heterogeneous, actinomyces groups dominates genuous in the supragingival plaque, advanced periodontitis, amoebas and trichomonads. Specific microorganisms sometimes causes an inflammatory reactions of the gingiva, although the clinical appearances may be entirely non-specific. Monoleal or a tuberculous, herpes simplex virus, fusospirochetal organism, necrotizing ulcerative gingivitis, streptococcal and staphylococcal gingivitis. Coming to the calculus, whether in a superficial gingiva or a subgingival causes irritations of the contracting gingival tissues. This irritation is probably caused by the byproducts of the microorganisms. Although the mechanical frictional resulting from the hard rough surface of the calculus may also play a role. Coming to the necrotizing gingivostomatitis. Necrotizing gingivostomatitis, it is commonly includes necrotizing ulcerative gingivitis, necrotizing ulcerative periodontitis, and necrotizing stomatitis. So all these includes, and we call it as necrotizing gingivostomatitis, which includes necrotizing ulcerative gingivitis, ulcerative periodontitis, and necrotizing stomatitis. So necrotizing gingivostomatitis predisposing factors are emotional stress, immunosuppression, HIV infections, smoking, malnutrition, pre-existing gingivitis. So emotional stress is an main factors for necrotizing ulcerative gingivostomatitis or necrotizing ulcerative gingivitis or periodontitis. Immunosuppression, HIV infection, smoking, malnutrition, and pre-existing gingivitis. Diagnosing markers of immunodeteriorations in HIV is seropositive patients. Necrotizing ulcerative periodontitis and necrotizing ulcerative gingivitis shares many of the clinical and etiological characteristics, except that the former has known systemic diseases or immune dysfunctions and attachment loss. Only the immune dysfunction and attachment loss is the only difference between each of them. Coming to the necrotizing ulcerative gingivitis, it is also known as Vincent infection or trench mouth, acute ulceromembranous gingivitis, phalangic gingivitis, fusous spirochetal gingivitis, and acute ulcerative gingivitis. These are the other names of necrotizing ulcerative gingivitis. Necrotizing ulcerative gingivitis, it is a specific type of gingivitis which characterize signs and symptoms, diseases manifestations as both acute and recurrent phases. Inflammatory conditions involve primarily the free gingiva margin, the crest of the gingiva, and interdental papillae. When it spreads to the soft palate and tonsillar area, it is called as Vincent angina. Diagnostic triad, it is usually pain, interdental ulceration will be seen, and gingival bleeding. So these acts as a triad where when a patient is complains of pain, and when you observe it is an interdental ulceration and there is an gingival bleeding, you can come to a provisional diagnosis of necrotizing ulcerative gingivitis. Coming to the epidemiology, it is frequently occur in an epidemic pattern. Groups of persons in close contacts, especially those living under similar conditions, apparent during which was seen in the World War I, termed trench mouth, where troops of the warriors where it was first diagnosed. Similar sporadic outbreaks also occurred during the World War II, relatively uncommon in developed countries nowadays. Global increasing associated with HIV infections. Coming to the etiology, it is an endogenous polymicrobial infection causing destructive inflammation due to coexistence of several predisposing factors. Fusiform bacillus and Borrelia vincenti, which is present in the smaller number in the healthy gingiva flora, it causes fusiforms and filamentous organisms are also formed. Increase in IgG and IgM antibody titers to spirochetes and increase in IgG titers to Bacteroides melanogenesis. Coming to the clinical features, it is painful, hyperemic gingiva and sharply punched out craters like erosions of the interdental papilla of sudden onset, ulcerated remnants of the papilla and free gingiva bleed when it is touched. It becomes covered by a greyish green or necrotic pseudomembrane. Ulcerative tends to spread and may eventually involve all gingival margin. It begins rather commonly at a single isolated focuses with a rapid onset. So usually the clinical feature is it is painful, hyperemic gingiva and sharply punched out crater like erosions of the interdental papillae, and it is a sudden onset. It is one of the main clinical features, and ulcerative remnants of the papilla of free gingiva bleeding when it is touched. So when you touch it, there is a bleeding and there is a greyish green necrotic pseudomembranous will be formed on the teeth or gingiva. Ulceration tend to spread and may eventually involve all gingival margins. So all gingival margins will be involved. It begins rather commonly at single isolated focus and with rapid onset. So where single isolated focus, it starts in one area and all of a sudden rapidly it spreads with the other area or the adjacent area. A fetid odor ultimately develops that is extremely unpleasant. There will be an odor. The patient almost always have a chief complaints and an inability to eat because of the severe gingival pain and tendency of gingival bleeding. Pain is that of superficial pressure. Patient usually suffers from headache, malaise and a low grade fever. Excessive salivation with the presence of metallic taste to the saliva is often noted. Regional lymphadenopathy will be present. So the patient is always have a chief complaint of inability to eat because of the severe gingival pain and tendency of gingival bleeding. The pain is that of a superficial pressure. The patient usually suffers from headache, malaise and a low grade fever. Excessive salivation will be seen, which is of metallic taste, and saliva is often noted. The regional lymphadenopathy will be present. In advanced and more serious cases, there may be generalized or systemic manifestation, leukocytosis, gastrointestinal disturbances or tachycardia. After the necrotizing ulcerative gingivitis is cured, the crest of the interdental papillae which have been destroyed, leaving a hollow out area which constitute an area with retained debris and microorganisms which serves as an incubation zone. So this is an important clinical feature where after the necrotizing ulcerative gingiva is cured, the crest of the interdental papillae, as you can see the interdental papillae which have been destroyed, leaving a hollow out area inside the interdentally, there is an hollow out area where this hollow out area acts as a incubation zone for the microorganisms. So coming to the diagnosis based on smear studies is hazardous because of the non-specific findings. Although the presence of the disease can often be confirmed when vast numbers of spirochetes and fusiform bacteria are seen, it may be also present in normal mouth, acute hepatic gingivostomatitis, simple pericoronitis, marginal gingivitis and chronic gingivitis. Final diagnosis is made clinically. So coming to the histopathological features, it is acute gingivitis with extensive necrosis will be seen. The surface epithelium is usually ulcerated and it is replaced with thick fibrinous exudate, which is a pseudomembrane containing many polymorphonuclear neutrophils and macrophages. A lack of keratinizations of the gingival tissues. Connective tissue is infiltrated by the dense numbers of polymorphonuclear neutrophils and shows an intensive hyperemia. Microscopic features is an entirely non-specific one. Vast numbers of both spirochetes and fusiform bacilli are found on the surface of the living tissues in and beneath the necrotic pseudomembrane. Both forms have also been reported as invading variable tissues to variable depths below the surfaces. Coming to the desquamative gingivitis, it is not a disease entirely, but you can call it as it is a clinical term. Basically, it is not a disease, it is a clinical term where it is unique conditions of the gingiva characterized by intense redness and desquamations of the surface epithelium. Inflammation of unknown etiology, basically it is idiopathic, and it is also called as gingivosis. So you can see the clinical picture shows there is a redness, right? You can see the reddish area. What are the etiological factors? Certain dermatosis, hormonal influences, abnormal response to irritations, chronic infection, and it is an idiopathic. The most important dermatosis presenting oral findings is characterized by desquamative gingivitis is cicatricial pemphigoid, pemphigus, lichen planus, epidermis bullosa, SLE, systemic lupus erythematosus, linear IgA diseases. Coming to the gingival abscess, usually gingival abscess is an acute, localized and painless lesions of the sudden onset caused by sudden forceful penetration of any foreign objects. Any foreign objects, it is get intruded between the gingiva, there is a gingival abscess. It is bristles of toothbrush and apple core, anything which is sharp, which can leads to this gingival abscess, where it carries a bacteria deep into the gingival tissue. These areas are the gingival abscess. Clinical features, it is usually limited to the marginal gingiva. Initially it appears as reddish swelling with a smooth and shiny surface. Within hours it becomes fluctuant and exhibits pointing and through which pus discharges. Coming to the histological features, the connective tissue shows vascular encroachment, edema and formation of abscess cavity surrounded by diffused collections of polymorphonuclear neutrophils. Epithelium exhibits secondary changes, intra and intercellular edema, fibroabscess formation, sometimes ulceration. Treatment, usually it is spontaneous rupture is common. This invading foreign material, if any, will be usually expelled along with the pus. So, if there is any foreign object inside it, it will come along with the pus. Coming to the gingival enlargement. Gingival enlargement is an increase in size of the gingiva. So, the soft tissue overfills the interproximal spaces. As you can see, there is an fill in the interproximal spaces. It is usually a increase in size of the gingiva. As you can see, there is an increase in size of the gingiva. It is not an usual one. Ballooning out over the teeth and protrudes into the oral cavity, may be localized to one papillae or may involve several or all of the gingival papillae throughout the mouth. It can be localized or it can be seen in throughout the mouth. The gingival enlargement is usually more prominent and labial and buccal surfaces. Although it does occlusally develops in the lingual area, it does not involve the vestibular mucosa. You should not be confused with the overgrowth of the bone or extosis noted occasionally on the alveolar bone. Coming to the etiology, inflammatory gingival enlargement, drug-induced gingival enlargement, enlargement associated with the systemic factors, conditioned enlargement, enlargement due to systemic diseases, idiopathic gingival enlargement, neoplastic enlargement and pseudo or false enlargement. So, these are the classification based on the etiology. Coming to the inflammatory enlargement, local irritants, if there is a poor oral hygiene, accumulations of dental plaques or calculus or mouth breathing, host tissue response to the dental plaque accumulation will be seen, and clinical features gingiva or soft and edematous, hyperemic or erythematous, sensitive to touch, bleeds easily, glossy and non-stipple surface. So, usually it is soft and edematous, it is very soft and it is inflamed. Erythematous, it is reddish, sensitive to touch, as soon as you touch it bleeds, and it is glossy and stippling will be absent. So, stippling is one of the normal clinical features where you can observe in the healthy gingiva. If stippling is absent, you can come to a diagnosis where it is an unusual clinical feature seen in the gingiva. And histopathological features, it is hyperemia, edema, lymphocytic infiltration, proliferation of the fibrous connective tissue of the gingiva. So, this is an clinical picture of inflammatory enlargement gingiva due to local collections of plaque. So, it is based upon the plaques. If we remove the plaques, it can reverse. Drug induced gingival enlargement, usually anticonvulsant drugs, immune suppressants, calcium channel blockers, hydantoins and phenytoins. These are the drugs which induces the gingival enlargement. Patient taking anticonvulsant, that is valproic acid or any anticonvulsant drugs, immune suppressants, calcium channel blockers, hydantoins and phenytoins. So, this is one of the clinical picture where enlargement of the gingiva in an epileptic patient receiving Dalton sodium. So, as you can see, there is a enlargement of the gingiva. So, coming to the clinical features, it is painless. As you can see the clinical picture, it is overgrown, but it is painless, involving one or two interdental papillae, increased stippling and ultimately a roughened or pebbled surface with lobulation. Gingival tissue are dense, resilient and insensitive. It shows little or no tendency to bleed. So, you can see it has been overgrown, it is painless and it does not bleed. Coming to the enlargement associated with systemic factors, mainly hormonal enlargement, allergic enlargement and nutritional enlargement. Hormonal enlargement is usually seen in pregnancy and puberty. Allergic enlargement, plasma cell gingivitis, also called as atypical gingivitis or plasma cell gingivitis. It arises in hypersensitive reactions to components of chewing gums, dentifrices or some of the dietary components. It is commonly present in the mild marginal gingiva enlargement, sometimes extending to involve the attached gingiva. More prevalent in young women. Initial symptoms is soreness of the mouth, which is intensified by hot or spicy food. So, this is a clinical picture of plasma cell gingivitis. Allergic enlargement of plasma cell gingivitis, it is severe cases extending to buccal and vestibular mucosa. Gingiva appears swollen, erythematous, friable with loss of stippling. The involvement of the oral tissue like the tongue and lips is common. They appears atrophic, dry and exhibits crack or fissures. Coming to the histopathological features, the surface epithelium is hyperplastic, shows intracellular edema and micro abscess. Connective tissue is dense, infiltrated with chronic inflammatory cells and predominantly a polyclonal mixture of plasma cells, marked vascular dilatations with severe thinning of epithelium over the connective tissue pegs. So coming to the last slide, which is the treatment and prognosis part, where it is possibly allergens should be identified, careful study of the patient history and eliminations, topical and systemic steroids gives good results. So these are the treatment and there is a good prognosis of the disease. Thank you students for watching my class.